All right, thanks for joining. We'll be discussing a clinical case of multi-organ manifestations of heterotaxy. I'm Benjamin Zielonka, a cardiology fellow, and Prasanna Ramachandran from gastroenterology and Ye-Sun from pulmonary will also be presenting with me. So this patient had a prenatal diagnosis of heterotaxy and a single ventricle cardiac defect. They were noted to have abdominal situs ambiguous with a left-sided stomach and midline liver and functional single right ventricle involving a right dominant atrioventricular canal defect and hypoplastic left-sided structures with retrograde flow in the aortic arch. The pregnancy was notable for severe in utero growth restriction, and the patient was delivered at 33 weeks gestation with a birth weight of 1,300 grams. Because heterotaxy can be associated with complex congenital heart disease, a systematic approach to the intracardiac and vascular anatomy is helpful for understanding the range of defects. This table shows a general schematic of common cardiac manifestations in both the left atrial isomerism or polysplenia and right atrial isomerism or asplenia forms of heterotaxy. However, many patients, like the one in this case who had left atrial isomerism, have anatomy that does not fit perfectly into these generalizations. This patient had an interrupted inferior vena cava with azygous continuation to the right-sided superior vena cava, normal pulmonary venous drainage, and as mentioned, had a atrioventricular canal defect in functional single ventricle. There was systemic outflow tract obstruction and normally related great arteries. Single ventricle palliation is an important topic in heterotaxy because historically more than 50% of patients that have heterotaxy have defects that require single ventricle palliation. Heterotaxy is associated with worse outcomes in children that undergo single ventricle palliation, and after the initial operation that's required. This figure shows the proportion of patients that have death or transplantation after the initial operation, and shows that about 30% of patients in this single center series had either death or transplantation before undergoing their second operation, compared to less than 20% in children without heterotaxy. The reason for these differences are multifactorial, but involve pulmonary venous obstruction, atrioventricular valve regurgitation, and extracardiac complications. Returning to our patients in terms of their course, at birth, they were started on a prostaglandin infusion in order to maintain patency of the ductus arteriosus. At 1 week of age, they underwent a hybrid procedure in the setting of prematurity and low birth weight. This involved placement of pulmonary artery bands and continuation of prostaglandins in order to ensure that blood flow would reach the systemic circulation. Over the next several weeks, they remained in the cardiac ICU to achieve further growth. And at 6 weeks of age, they underwent a stage 1 operation with placement of an RV to PA conduit, also called a SANA.
From a liver standpoint, the patient had gradual worsening of hyperbilirubinemia even after the stage 1 palliation and resumption of full enteral feeds, as seen in this graph. The cholestasis was not improved even with ursodiol supplementation. Hepatology was consulted to evaluate the worsening cholestasis. The pattern of cholestasis was consistent with extrahepatic disease. Additional workup was initiated that included an abdominal ultrasound that did not visualize the gallbladder and common bile duct. A hepatobiliary immunodiacetic acid, or HIDA scan, revealed absence of tracer in the duodenum, raising suspicion for biliary atresia. An intraoperative cholangiogram confirmed the diagnosis of biliary atresia, and a Kasai poroanerostomy was performed with resolution of cholestasis subsequently. The Kasai procedure has allowed for continued biliary drainage in this patient, and there have not been signs of portal hypertension or worsening disease as of now. Biliary atresia is a rare but serious neonatal cause of jaundice, and it can cause irreversible liver damage. The etiology of BA is not well understood. It's thought to be multifactorial, with both genetic and environmental contributions to disease development early on in the neonatal or perinatal period. The Kasai surgery is a stopgap measure, allowing the infant to grow, and most BA patients ultimately require a liver transplantation. The timing of the Kasai procedure is important though, and surgery before 2 to 3 months of life is strongly associated with improved outcomes and reduced mortality. Most cases of BA are non-syndromic, as shown here, but up to 15% are associated with laterality malformations. This study from Germany looked at the prevalence of BA in patients diagnosed prenatally with heterotaxy. Interestingly, in this series, all patients subsequently diagnosed with BA had left isomerism. We also know that BA is associated with direct or conjugated hyperbilirubinemia early in the neonatal period. This study from Houston, Texas, showed that all patients with BA have direct hyperbilirubinemia that is evident right at birth. Based on the results of this study, a screening program was implemented across the hospital to test all newborns for levels of total and direct bilirubin at birth. The program successfully reduced the time to Kasai from a median of 62 days prior to implementation to 26 days after implementing the screen.
From a pulmonary standpoint, immediately after birth, this patient had respiratory distress requiring CPAP support, which he was maintained on between his multiple cardiac surgeries. After this, he was able to be weaned to room air, and also noted after birth was persistent nasal congestion. At around 1 year of age, due to persistent desaturations, he was ultimately started on low flow nasal cannula. Due to these respiratory issues, he had a PZV workup done, including whole exome sequencing, which revealed one pathogenic heterozygous splice mutation in CCBC39, which is associated with defects in ciliary ultrastructure and tends to be associated with more severe phenotype. Additionally, one heterozygous VUS and DRC1, which is associated with PCB, along with heterozygous VUS and PDK1L1, which is associated with heterotaxy, was detected. He also had a ciliary biopsy done where the electron microscopy revealed 20 evaluable cilia with pound cilia, which was noted to have normal ultrastructure. Due to the desaturations, he also had a bronchoscopy done, which revealed significant tracheobronchomalacia with almost complete collapse of the left mainstem bronchi and 50% narrowing of the lower trachea. During the first 1 to 2 years of life, he had multiple admissions for respiratory issues and had respiratory cultures that ultimately grew Pseudomonas, Serratia, Klebsiella, and Enterobacter. Due to persistent cough, he was also started on daily airway clearance with albuterol, saline, and chest physiotherapy. With his persistent desaturations, he underwent a cardiac cath when he was about 1.5 years of age after the stage 2 Kawashima procedure, which revealed numerous bright lung AVMs with evidence for collateral vessel development, after which he underwent embolization of these AVMs. He also underwent workup for immune dysregulation, had a swallow study to assess for dysphagia, as well as sleep study to assess for potential contributors to hypoxia, which were all negative. Due to the microscopic nature of AVMs afterwards, he did not undergo further embolization. After his final fenestrated Fontaine procedure at 2 years of age, his subsequent cath showed resolution of previous pulmonary AVMs, and he has subsequently been able to be weaned off of supplemental oxygen altogether. His chest X-ray at 3 years of age shows relatively pure lungs, and he is doing very well from a respiratory standpoint currently. In patients with heterotaxy, there's a high prevalence of respiratory disease, and especially ciliary dysfunction. In this multi-center study of heterotaxy patients, ciliary dysfunction was found in a large portion of patients, especially those with abdominal lung laterality defect. It's important to note in this study that none of the patients in this cohort had genetically verified PZV. And similarly in this patient, while he did not meet criteria for genetic diagnosis of PCV, his clinical features such as chronic year-round cough and rhinitis are certainly consistent, and as such warrant treatment with airway clearance and monitoring with respiratory culture. Additionally, airway malformations such as tracheal bronchomalacia has a rare but potential association with heterotaxy, along with lower airway stenosis, which could be associated with worsened clinical outcomes. Lastly, pulmonary AVMs are found in heterotaxy patients. Those with interruptions of the IVC are at particular high risk for pulmonary AVMs. And the cause of this is thought to be due to decreased hepatic factor, particularly as incidents of pulmonary AVMs tend to resolve after resolution of hepatic venous flow, which was seen in this patient. In summary, children with heterotaxy and single ventricle heart disease Multiple extracardiac complication of heterotaxy can be associated with significant comorbidities. In all children with heterotaxy, early screening for direct hyperbilirubinemia and early referral to hepatology is warranted in the presence of persistent cholestasis. Pulmonary assessments or other causes of hypoxia, authorization evaluation for pulmonary AVMs, as well as workup for PCD and airway evaluations are important. And with that, here are our references, and we're happy to take any additional questions.